Welcome back to Critical Moments with the Neonatal Nurse Educator, Part 19. You are taking care of an ex-28-weeker who is now 4 weeks old, 32 weeks in their bed. They are showing signs of sepsis, and the providers ordered for them to be NPO and an IV to be placed. If they are snugged nicely like this, we may need to get access to a limb so that we can start the IV and leave that limb exposed. So make sure that you are using your developmental positioning devices to your benefit as you're helping this baby. Once you get that IV started, what you need to be thinking about is what is safe to run through this IV. If the infant is getting sicker, this is your critical moment. Will my access support the medications I need to give? And you know that I don't believe in an always and a never, because there are times in the NICU where we have to do things outside of our standard practice. However, things we standardly run through our IV would include dextrose concentrations up to D12.5. We would run antibiotics, a normal saline bolus if we had a low blood pressure, a D10 bolus if we had a low blood sugar. We may have to run low levels of dopamine until we establish central line, because on a 4-week-old, we can't throw in an emergency UVC. In these situations, even things like calcium gluconate, sodium bicarb, we don't love to put any of that or really concentrated TPN into an IV, but we may have to do that for short-term access in emergency situations. It is important and critical for you as a bedside nurse to know what can and cannot go through your peripheral IV the majority of the time. Remember, greater than D12.5, we're going to need a central line. Dopamine really in rising levels or above 5 mics, we're going to need a central line. Any of those inotropes, vasoactive medications, prostaglandins, hypertonic solutions, think it might be time for a central line.